Good afternoon, and welcome to our webinar, The Healthcare Exchange, You and Your Patients. My name is Allison Jones, and I am the Director of Marketing at MD Everywhere. So let's jump right in and talk about the Healthcare Exchange and what it means to you in your practice. We've been hearing about it for years and talking about it for months. The Healthcare Exchange, the marketplace for uninsured Americans and small businesses to shop for the best rates and plans to fit their needs. In today's webinar, we will provide an overview of the Healthcare Exchange, share some details about the newly insured Americans, and explore the potential impact on providers as these millions of newly insured Americans start receiving medical services under the new Healthcare Exchange. So let's get started. The healthcare marketplace, also known as the healthcare exchanges, are organizations set up to facilitate the purchase of health insurance in each state in accordance with the Patient Protection and Affordable Care Act, commonly referred to as Obamacare, even though the model has been on the table for many administrations prior to the current one. The marketplaces provide a set of government-regulated and standardized healthcare plans from which individuals may purchase health insurance policies eligible for federal subsidies. President Barack Obama promoted the concept of a health insurance exchange as a key component of his healthcare reform initiative. Obama stated that it should be a market where Americans can one-stop shop for a healthcare plan, compare benefits and prices, and choose the plan that's best for them, in the same way that members of Congress and their families can. None of these plans should deny coverage on the basis of a pre-existing condition, and all of these plans should include an affordable basic benefit package. That includes the prevention and protection against catastrophic costs. When identifying what the typical insurance shopper's age would be, the expectations in 2010 were that 31% of newly insured would be under the age of 25, while a total of 72% would be under the age of 45. 26 would be between 45 and 64, and another 2% would be in the over 65 age group. According to a 2013 KCMU analysis, reasons for being uninsured varied. 32% felt it's not affordable, 8% aged out when they left school, 30% lost their job that provided their coverage, and the other 29 to 30% had various reasons or felt there was no need for insurance. As a result of their 2013 research, the Healthcare Trends Institute published this evolution guide to explain how the exchanges would work, who will be using them, and what it means for consumers in 2014. 12 million Americans were expected to begin using the exchanges, with 40% of the enrollees coming from just 5 states. 75% of the exchange population will not have college degrees. 60% of the audits entering the marketplace 60% of the adults entering the marketplace will be employed full-time. 60% will have incomes below the federal poverty level. Employers have a $2,000 fine per employee for dropping coverage. And the projections estimate that by 2021, the state insurance exchanges will translate into a $205 billion market opportunity for the healthcare sector. Those were projections, so let's see what actually happened. Enrollment in the marketplaces started back on October 1st, 2013, and continued through April 30th, 2014. While there were some technical glitches with the marketplace initially, from October 2013 to January 3rd, 2014, 2 million people had selected a health plan through the health insurance marketplace, and that number rose to just over 8 million people, with an additional 4.8 million joining Medicaid by mid-April. Who registered? So after all the projections and theories, who did actually enroll in the healthcare exchange during the 6-month open enrollment phase? Here are just a few of the statistics released in a summary enrollment report by the Department of Health and Human Services on May 1st of 2014. Marketplace eligibility determinations and plan selection said that 8 million eligible persons selected a plan. Eligible persons over the age of 35 signed up earlier in the open enrollment period, while there was an increase in enrollment in the age 0 to 34 group in the last 30 days. 46% of enrollees are male, 54% are female, 6% are below the age of 18, 28% between the ages of 18 to 34, and 66% of enrollees are above age 35, and 25% are between ages of 55 and 64. Let's talk a little bit about how healthy these newly insured are. Analysts anticipated that with the younger Americans becoming insured under the new plan, costs would be manageable, expecting that most would be in better health than more mature Americans. But that's not what they got. While the Obama administration hasn't yet released a breakdown of the enrollment figures that would allow for full analysis for the first year of signups through the exchange marketplace, according to a recent Gallup poll, younger and unexpectedly unhealthier Americans make up the majority of the newly insured. Of the 5% of Americans who are newly insured under the terms of the Patient Protection and Affordable Care Act, 38% of those using the exchange for their new policies reported being in very good or excellent health, compared with 50% of the general population. That's a 12% difference. 24% report to be in fair or poor health, compared to 18% of the national adult population being in fair to poor health. Let's not overlook the private exchanges. You haven't heard much about them, but they've had a significant jump in the newly insured participants. Private exchanges are similar to the public marketplaces, but are offered by employers to their employees. Consulting companies operate private exchanges, and some insurers also offer their own versions. Walgreens and Sears, for instance, participate in one offered by Aon Hewitt, known as the Corporate Health Exchange. Some employers are shifting employees to the exchanges to control costs and reduce administrative burdens, and to give workers more plans to choose from. The idea is that offering plans from multiple insurers will help lower costs through competition. While details of the exchanges vary, companies typically allocate a specific amount for employees to spend on health insurance, and then workers choose from a menu of options. Benefits for employers are reduced costs, a more simplified administration process, and they're able to offer more options to employees. Benefits for the employees include more choices in their benefit selections to choose a plan that was the best fit with the right level of coverage based on their need. And more information, as the private exchanges often provide the sort of information required for consumers to improve their understanding of healthcare benefits, utilization, and costs. While most media coverage is focused on the public healthcare exchange, private exchanges have quietly enrolled 3 million people, which is more than most industry analysts expected. Accenture Consulting reports a projection that total enrollment in private exchanges could reach 40 million by 2018, surpassing the number of people enrolling through state and federally funded exchanges, as employers seek to control costs, give employees more choice, and reduce administrative burdens. The bottom line: there are 8 million more newly insured Americans today than there were just 8 months ago. And they'll be seeking care and shopping for providers just as they shop for their insurance plan. In a June 27, 2014 Vitals Index reports an increase in people shopping for doctors by insurance. They reported this: more than 4 times the number of people are basing their doctor decision on insurance this year compared to last. Compared to January 2013, the number of people searching via an insurance filter this January increased 1,034%. Let me say that again. I said 1,034% increase in the number of people searching for providers over the number looking for providers in January of 2013. Mitch Rothschild, who's the CEO of Vital Index Reports, believes because of higher deductible plans and people paying more for each doctor visit, there's an increased focus on not only finding quality doctors, but doctors who are in-network. So let's take a look at what the newly insured can expect. We'll examine some barriers first. Panelists who participated in a May 2014 roundtable discussion sponsored by the Connecticut Center for Patient Safety cited barriers the newly insured face in getting health care, along with a wide range of potential pitfalls. Getting coverage eliminated. Here's the reality today's newly insured are facing. Most people bought insurance without properly understanding their plans. There's a lot of confusion about copays, deductibles, inpatient versus outpatient coverage, and maximum out-of-pocket costs. Many people bought insurance based solely on the premiums, the upfront costs they must pay each month, without really realizing how much they might have to pay when they get care. People who shop in the exchanges are realizing that plans they bought don't cover a drug they need, or they didn't realize that they have to pay more than $6,000 toward a deductible before the plan would begin paying for service. It can be nearly impossible to find the details about what drugs a health plan covers. Prescription drugs are a particular challenge because there have been significant changes to cost-sharing requirements. Major drugs are not covered the way they used to be, and that's going to affect many people. Medications that used to be covered by a $40 copay could now cost $500 out of pocket per month. Some new patients feel disrespected by doctors who rush through their appointments or spend the visit looking at computer screens, making them unlikely to go for a second appointment. Given the increase in patients, some doctors tell their patients at the start there's a 10 to 15 minute limit to the appointment. Patients complain that their appointments are rushed and feel like a fast food drive-through type of service. And with the increased use of electronic medical records, patients perceive their doctors spending more time entering information into the computers and making sure they can bill for services than making eye contact and talking to the patient. Patients who don't speak English often have to rely on a patchwork of inadequate solutions to communicate with a doctor. Because qualified interpreters are overbooked, medical offices often revert to having staff interpret, even if they're not qualified to translate medical terminology, or some practices also provide a language line that people can call for translation. But patients often find it cumbersome and uncomfortable to share personal medical information with someone over the phone. With 60% of newly insured being below the federal poverty level, cars or public transportation can be a challenge. Without access to a car, they struggle to keep medical appointments, and practices can expect to see an increase in their no-show rate. Many patients are having difficulty finding physicians who are accepting new patients. And if they're accepting new patients, they don't have an opening for several months. According to the Health Resources and Services Administration, the federal agency charged with improving access to health care, nearly 20% of Americans live in areas with an insufficient number of primary care doctors. 16% live in areas with too few dentists, and a whopping 30% are in areas that are short of mental health providers. According to the Association of American Medical Colleges, unless something changes rapidly, there will be a shortage of 45,000 primary doctors in the United States by 2020. And some patients avoid seeing a doctor because they fear of being diagnosed with an illness. Even being diagnosed with something minor and treatable could mean more doctor visits, which equates to more out-of-pocket expenses for office visits, medication, and possible hospital stays. Some have the mentality that ignorance is bliss, and they'll let nature take its course. So what can you do? So let's focus on that and what providers can do to help themselves, their patients, and their community. First, familiarize yourself with the health plans that are being offered in your state. Have someone monitoring the cms.gov website for new information that could impact your state or specialty. Find an online resource that lists the states and plans available. MD Everywhere's website has a healthcare exchange resource page providing exactly that information. Consider accepting more of local plans that are now available to your patients. Know what your patients' needs are. Ask questions. Pull your patients when they call in or come in for a visit. Get a sense if they are considering changing insurance plans, and if so, do they know what plan they would move to? Advise them to read the fine print. Understand that what the true out-of-pocket cost is, and not just the monthly premium. They must consider co-pays, deductibles, and prescription coverage. Knowing patients are paying a higher portion of their healthcare costs out of pocket, provide an online payment portal and offer payment plans to help them manage the higher deductible plan they may have selected. Offering payment plans may make the difference of collecting some or all of the patient balance versus none of the patient balance. By the way, MD Everywhere provides their clients with Patient First, an online patient portal, making it easier for staff and patients to manage the patient payment portion of the medical costs. It's time to grow. Bring in a partner, hire another doctor, or considering adding a PA or NP to help manage the increased patient volume. While it's considered a controversial idea, many states have passed legislation to allow nurse practitioners and physician assistants to do some of the work usually reserved for doctors. Using PAs and NPs can also resolve the anticipated problem of a physician shortage. Another solution is to use community health workers to bridge gaps between the medical professionals and patients by providing simplified information that's easy to apply to people's lives. If patients need to eat a diabetic healthy diet, for example, community health workers could help them adapt recipes from their culture and shop in local stores. Extend business hours. The healthcare system will need to adapt to the needs of patients. Among the changes to consider is extending office hours by offering appointments at night and on weekends. The weekday 9 to 5 schedule won't survive in this new environment. Consider alternative business models and use new technologies that can extend the reach of medicine in ways that will alleviate the physician staffing problem. For example, healthcare professionals can serve more people by using Skype or other telemedicine technologies to examine, treat, and monitor patients. Similarly, patients can be fitted with electronic devices that remind them to take their medications and provide other guidance about their conditions. These and other technologies are already keeping patients out of the hospitals and doctors' offices. Fast facts tagged with telemedicine include improved accessibility to specialist care, reduced hospitalizations resulting in lower treatment costs for chronic patients. It enables early, proactive intervention for follow-up care. It enables caregivers to take a more active role in the care of family members, and improves the efficiency by enabling medical professionals to focus on patients who need them the most. Healthcare benefits of live video conferencing include improved access to specialty care for rural and underserved patients, earlier diagnosis and intervention for chronic conditions, fewer redundancies in tests, lab work, and exams, reduced the cost of care by up to 6% in overall, but 42% for follow-up care, reduced wait times, and improves training and education of medical interns. Other models to consider in regard to the changes in the ways medicine is delivered is the use of patient-centered medical homes and accountable care organizations to better coordinate patient care. They are expected to improve efficiency and keep patients out of the hospital. These organizational changes will make primary care physicians more important than ever, which might make primary care a more appealing and lucrative career choice. The patient-centered medical home is a team-based healthcare delivery model led by a physician that provides comprehensive and continuous medical care to patients with the goal of obtaining maximum health outcomes. It is an approach to providing comprehensive primary care for children, youth, and adults. The provision of medical homes may allow better access to health care, increase satisfaction with care, and improve health. In contrast, an accountable care organization is a healthcare organization characterized by a payment and care delivery model that seeks to tie provider reimbursement to quality metrics and reductions in the total cost of care for an assigned population of patients. A group coordinated healthcare providers forms an ACO, which then provides care to a group of patients. The ACO may use a range of payment models, capitation, fee-for-service with asymmetric or symmetric savings, etc. The ACO is accountable to patients and the third-party payer for the quality, appropriateness, and efficiency of the health care provided. According to the Centers for Medicare and Medicaid Services, an ACO is an organization of healthcare providers that agrees to be accountable for the quality, cost, and overall care of Medicare beneficiaries who are enrolled in the traditional fee-for-service program who are assigned to it. So by now you can begin to understand the impact the healthcare exchanges will have on the healthcare industry as a whole, and more specifically on physicians, other medical staff, private practices, and most importantly, the 11+ millions of newly insured Americans. So here are some key takeaways. There are 11 million newly insured that will be scheduling appointments for medical care. Millions of them are in fair to poor health, meaning the level of care needed will be more than just preventative medicine. They are shopping for providers, and you need to be available to take on new patients in order to meet the demands of our community and grow your business. Understand your patient needs. From plan choices to out-of-pocket costs, the prescription coverage you need to know what the available plans are and which ones your patients have selected. Make changes now to meet the needs of your patients. Reorganize staff to be able to add those newly insured to your patient base. Increase both the medical as well as support staff in your office and expand office hours. Enroll in and accept new plans specific to your state. Consider new technology. Patient payment portals offer convenient options for patients to pay the higher deductibles. Train your staff to collect patient balances at the time of the patient visit. Post-patient balance payment policies so patients are clear what their responsibilities are in paying their portion of the bill. Consider telemedicine or video conferencing options to improve access to specialist care and reduce hospitalizations, resulting in lower treatment costs for chronic patients. Consider alternative business models in the form of patient-centered medical homes or an accountable care organization. Both models are designed to improve the quality of care and overall patient management while reducing costs. So that brings us to the end of the presentation on the healthcare exchanges, you and your patients. If you have any questions on the presentation, please submit them using the question and answers tab, and a representative will reach out to you directly with a response. But before we wrap up, I'd like to take a moment to talk about MD Everywhere. Our ICD-10 ready, purpose-built revenue cycle management technology, combined with our claims processing and back-end services, allow us to improve processes and increase revenue for our clients. We offer a fully integrated 2014 certified EHR solution so we can meet all of your revenue cycle and EMR needs. And we are pleased to announce that once again, we've been awarded the NCQA certification. MD Everywhere's CVO and credentialing division can handle all your Medicare revalidation needs also. And with approximately 7,000 physicians nationwide and over 40 different specialties using our services, we pride ourselves on maximizing revenue for our clients while meeting all their RCM, EMR, and credentialing needs. We encourage you to contact MD Everywhere if you want more information about our services or if you have any questions about today's webinar. You can reach us online at mdeverywhere.com, or you can email questions@mdeverywhere.com, or call us at 631-232-4260. Press option 4 and pound. I also invite you to join us for our upcoming August event, our Express webinar on consumerization of health care, planned for August 13th at 1 p.m. Eastern Time. If you'd like to register for that event, please visit our homepage and scroll to the bottom where you can see a listing of upcoming events. We thank you for your time today, and we hope you found this session educational and informational. We look forward to seeing you again at the next webinar.